Welcome, my name is Cornelia Schaefer-Prokop, and I will talk to you about subsegmental and incidental pulmonary emboli, diagnosis and treatment. The rationale for my talk is that traditionally all pulmonary embolism are anticoagulated in a similar manner, independent of location, number and size of thrombi. With modern CTPA, we know that there is an increasing visualization of the peripheral pulmonary arteries and therefore also an increasing rate of diagnosis of small pulmonary emboli. And a question arises, do they all need to be treated and do they all need to be reported? What are subsegmental arteries and subsegmental pulmonary emboli? The subsegmental arteries are defined by the fact that they are derived directly from a segmental artery division, meaning that we talk about the fourth generation and going towards the periphery. Subsegmental emboli are intravascular defects limited to the subsegmental arteries. And we are not surprised that with increasing number of slices, going from 4 slice scanners to 64 slice scanners, for example, and to decreasing thickness of slices, we will see those intravascular defects in the peripheral arteries more frequently. Limitations have been reported for segments 5 of the middle lobe and the lingula due to their in-plane course of the arteries, and for segments 7 and 8 in the left lower lobe due to pulsation artifacts. Unsuspected pulmonary embolism, with the abbreviation of UPE in the literature, refer mainly to cancer patients because they do suffer from an increased risk for venous thromboembolism. That also depends on comorbidities, on the primary tumor site. It's especially increased for brain tumors, pancreas tumors, stomach, kidney, ovary, and lung tumors, but also for patients with lymphoma and myeloma. It depends on the type of therapy they are undergoing. And it's not only true for cancer patients, but also for trauma patients, mechanically ventilated patients, and unsuspected pulmonary emboli have been reported in a very high percentage in post-mortem autopsy studies. What I want to discuss with you are aspects of the diagnostic performance for subsegmental pulmonary emboli in terms of sensitivity, role of dual energy and perfusion, interreader variability. We will discuss some aspects of clinical significance and at the end discuss the controversies with respect to the management. Let's start with the diagnosis. There has been a very nice publication with a somewhat provocative title, "When a test is too good, how CT pulmonary angiograms find pulmonary emboli that do not to be found." And this article describes an explosion in use of CT imaging, a 14-fold increase of CTPA in the years 2001 to 2008. At the same time, there has been evidence of overdiagnosis. There's an 80% increase of PE diagnosis with CTPA, but age-adjusted mortality from PE did not change, suggesting an increasing diagnostic rate of low-severity disease. And this is an image example just showing you here in the blue circles how small these subsegmental arteries and consequently the intravascular defects can be. And note here in yellow, this is not an artery, this is a vein with an irregular perfusion. As you can see here in the corresponding lung window, here is the vein and here is the peripheral defect. Going from single slice scanners to 4 detector scanners, 16 detector rows or 64 detector rows, there has been reported an increased percentage of isolated subsegmental pulmonary emboli going from 4.7% to 15% due to the increased spatial resolution. Another image example showing here in the axial view and in the coronal view some small intravascular defects, and I can only encourage you not only to look at the axial slices but also at the coronal slices or sagittal slices to make sure that you are diagnosing and talking about a true intravascular defect in these small peripheral arteries. Low kV, 80 kV, increases the visibility of peripheral arteries. One of the first publications talking about that, Radiology 2006, reported a significantly increased visualization of the subsegmental arteries going from 55% to 71%. And this has been reconfirmed by multiple studies. This is just another study who did not report a significant difference for the central arteries, but for the peripheral arteries there had been a significant increase from 53% to 92%, going from 140 kV to 80 kV. What about the inter-reader variability, the reproducibility of these findings? One of the first studies talking about that, and this was still a 16-slice scanner, reported an overall kappa between 0.8 and 0.9 for the diagnosis of pulmonary embolism, but a much lower kappa between 0.5 and 0.8 just for the evaluation of the subsegmental branches. And that has been reconfirmed, for example, by that study. They looked at all positive CTPA studies of 3 US community hospitals over 3 years and let them re-review the findings by 4 experienced chest radiologists. And they actually reported that, for example, 15% of the subsegmental defects, 14% of the intravascular defects smaller than 6 millimeter, and even 85% of defects reported in low-quality scans were actually false positive by this expert opinion. And the conclusion was that small pulmonary artery defects are not reliable indicators of pulmonary embolism. Other studies who actually find similar results reported in AGI in 2015 said that 60% of subsegmental pulmonary emboli were considered negative by reinterpretation, or another study reported that a substantial amount of so-called peripheral subsegmental pulmonary emboli had to be reinterpreted and actually were found to have also more centrally located segmental pulmonary emboli. Again, the conclusion of both studies was that if we are going to the peripheral arteries, and those findings will determine the management of the patients, a review of an expert radiologist is indicated. What about dual energy subtraction and these perfusion mapping images? Do they help us to find these small peripheral intravascular defects? And there has been a study, actually, it was an animal study. They found that in a substantial, significant amount, those small peripheral intravascular defects actually were seen better and with more confidence if those perfusion mapping images had been available. The next topic I want to discuss with you is the clinical significance. And this is actually what I just pointed out to you. For example, here we are comparing CTPA and dual energy CTPA, and you see a significant increase of the sensitivity, 96% to 24%. At the loss of specificity, the overall accuracy was increasing, and there was a notably high negative predictive value of dual energy images for the detection of peripheral emboli. Now I want to discuss with you the clinical significance. Why do we see more unsuspected pulmonary emboli in cancer patients? Because there are more CTs done in this patient group. There's better intravascular contrast or in non-dedicated CTs, and there's also higher awareness of the radiologists. However, we have to ask ourselves whether the image quality of these non-dedicated CTs is sufficient. And there has been a study who said that there is high reliability and reproducibility of reported incidental pulmonary emboli according to expert opinion. And this is an image example. You see this was an abdominal CT, and just in the first slices covering the chest, we did find by a chance incidentally intrapulmonary emboli in that particular patient with an peritoneal carcinosis due to an adnexed tumor. One of the first studies which alluded to the potential negative impact of treatment was that particular study. It was a retrospective single-center study including almost 2,000 CTs. They found PE in 120 patients, of which almost 50% had a malignancy. 48% of the PE were unsuspected, 2/3 were non-reported. Roughly 50 were treated therapeutically, some of them prophylactically, but a substantial number did not undergo treatment. And most importantly, they found significantly more bleeding complications in the treated group. A positive predictor of early death was high PE severity, major hemorrhage, new onset cardiac and renal failure, and systemic anticoagulation therapy. As opposed to a negative predictor of early death was a false negative report, the radiologist didn't see the pulmonary emboli, and no therapeutic anticoagulation. This is the table you have seen already when I reported to you that with increasing number of detector rings, we have an increasing diagnosis of peripheral pulmonary emboli. But at the same time, the 3-month risk of recurrent thromboembolism, which is one of the major outcome parameters, did not change. So we have to conclude from that that many of the negative CTPAs with single slice scanners who left the patients untreated probably and actually had subsegmental pulmonary emboli. What about VQ scans? There has been this statement that prospective management cohort studies showed that anticoagulation can be safely withheld in patients with a low probability VQ scan, a low number of zero markers, and negative compression ultrasound of the leg veins. And this particular patient group had a risk for recurrent thromboembolism of about 0.5%, with a range stated here, and this was comparable to the patients with a negative CTPA. And notably, those patients with low probability VQ scans, there was a substantial number of patients who actually had subsegmental pulmonary emboli in the PIOPET-2 study. So meaning that for many years, many patients with subsegmental pulmonary emboli have been managed without anticoagulation therapy. There is an increasing risk to the role of D-dimer. And that particular study evaluated whether an adjusted threshold of D-dimer, an increased threshold of D-dimer, is suitable to decrease the number of CTPA studies and subsequently decrease the number of diagnosis of peripheral pulmonary emboli which may be not to be treated. So that particular study, they included almost 700 patients, and they always combined one of these clinical decision rules, either the Wells score or the Geneva score. Then they looked at this classic D-dimer test, and if that would have been done consequently in that particular patient group, then they would have spared 110 CTPA studies because they had been negative, at the expense of that there had been 4 patients which actually had pulmonary embolism. If they would have increased the D-dimer to the double threshold, they would have spared 208 CTPA studies. Those patients would have not undergone a CTPA under CTPA examination at the price of a false negative result in 11 patients. So 11 patients would have not undergone the examination, but they did in fact had pulmonary embolism, but 10 of the 11 had only subsegmental emboli. None of them had concomitant DVT in the leg veins. So it would have saved up to 30% of examinations at the expense of 11 patients with small peripheral emboli. This has been reconfirmed by a huge multi-center study, the so-called ADJUST PE study. Again, they reported that the combination of age-adjusted D-dimer cutoff value and pre-test clinical probability can rule out PE with a low likelihood of recurrent VTE, and that has been published in German. The last I want to discuss with you is the management and the controversies around this management. To treat or not to treat if the patient has only peripheral subsegmental pulmonary emboli. There has been a meta-analysis, and they actually found that if these patients, that there is a substantial number, 7% risk of major bleeding in patients which have been treated for subsegmental pulmonary emboli. On the other hand, there was no episode of recurrent VTE in untreated patients. So they actually this alludes to the balance between risk of treatment on one side and necessity to treat those patients. And the result of that study was that withholding treatment may be safe under certain conditions. And those conditions are patients suspected for pulmonary embolism but non-diagnostic VQ scans with adequate cardiorespiratory reserve, low or moderate clinical probability, negative serial leg ultrasound, that is very important, no other major risk factors, no history of central venous catheterization or atrial fibrillation, and the willingness of the patient to return back for a serial ultrasound examination of the leg veins. So no treatment under certain conditions. This is a similar statement by another review actually, and this alludes again to the fact that CTPA of peripheral arteries should be diagnosed by an experienced chest radiologist. And again, they were alluding to the combination of pretest probability, D-dimer test, and the role of leg ultrasound to have a perceived risk of recurrent VTE smaller than 2%. This is the other direction. This was a study almost including 4,000 consecutive patients, and they actually found that there was no significant difference in terms of risk profile and clinical outcome between patients who have central pulmonary emboli and subsegmental pulmonary emboli. And on the other hand, there was an increased risk profile for patients having only small peripheral pulmonary emboli versus PE negative patients. And the result was actually that because of the similar risk profile between patients of central and peripheral pulmonary emboli, increased risk profile as compared to PE negative patients, that those patients should undergo treatment irrespective of PE severity. Similarly, results for cancer patients, they found substantial numbers of recurrent VTE, major hemorrhage, and a high mortality because of the comorbidity. They also compared different management arms, low heparin versus vitamin K antagonists, and the result of that comparison was recurrent VTE was comparable, recurrent VTE was higher if patients were completely untreated, and recurrent VTE was similar in patients with central or peripheral pulmonary emboli, but hemorrhage was higher with vitamin K antagonists. The conclusion was treatment irrespective of PE severity, but with heparin and not vitamin K antagonists. What about the large professional societies? And here I allude to ACCP, American College of Chest Physicians, and the National Institute for Health and Care. These are statements from 2012, and the statement was, do not consider a distinguished place for isolated subsegmental pulmonary emboli in contrast to PE from proximal sites, so every patient has to be treated. What about the unsuspected, the incidental finding of a pulmonary embolism? Again, also the American Society of Clinical Oncology, ASCO, says to treat incidental, recommends to treat incidental thromboembolism irrespective of whether it's centrally located or peripherally. And then they also state, with the exception of peripheral subsegmental pulmonary emboli, if it is thought to be an imaging artifact. And this alludes again to the relatively high interreader variability we discussed already previously. The European Society of Cardiologists published guidelines in 2014, and the statement was actually that the decision on whether they should be treated, but they also have a little bit like another statement, a backdoor. They say the decision on whether to treat should be made on an individual basis, taking into account the clinical probability and the bleeding risk. Cochrane reports, including randomized controlled trials, publishing summaries in 2014 and 2016, said there is no randomized controlled evidence for the effectiveness and safety of anticoagulation therapy versus no intervention in patients with isolated subsegmental pulmonary emboli or incidental SSPE, and therefore we cannot draw any conclusions. Well-conducted research is required before informed practice decisions can be made. Such well-conducted research is underway. There is a prospective management cohort study underway with including patients in France, Switzerland, and Canada, and results will be expected in 2017. Another next step is that there are more studies needed to look into the issue of adjusted thresholds of the D-dimer to rule out safely PE without use of CTPA. So what are the conclusions of my talk? Interreader variability is considerable for the diagnosis of subsegmental pulmonary emboli, especially if image quality is limited. New techniques such as low kVp and perfusion imaging are helpful. Though study results suggest that treatment can be withheld under certain conditions, the major body of professional societies currently recommend treatment irrespective of location and severity of PE, and prospective management cohort studies, a big study is underway to evaluate the options of a more individualized approach. Thank you very much.